here which has got a pseudoaneurysm. If we go in the mesentery inferiorly, we can see a thrombosed aneurysm. So this is historic, but there is no active bleed or aneurysm here. On the other hand, if you see this lowermost cut, you can see that there is a chronic infarction, and the cortex is irregular. So there is a chronic infarction. Then there is a aneurysm. At this point, there should not be any blood vessel inside. Now, if you see carefully, look at this cortex versus this cortex, and this cortex is enhancing less. So you have to point that out, that this is a acute infarction are developing, and maybe there is a bit of a already a defect there, so it must be acute over chronic type of infarction there. And now in this particular case, if we uh, go for a coronal, uh, in abdomen, there is absolutely nobody stopping you to ask for a coronal. If the examiners want to show it to you, it's fine. They will show you. Otherwise, they will not show you, but you are absolutely justified. Where it is relevant, please ask coronal. Just think in your clinical practice, what do you do? And there are places in which coronal will be very helpful. So in this particular case, now you can see small, tiny aneurysm, but this one is a definite aneurysm. You can see this irregularity, and you can see another developing this hypodensity, which I had shown you on the axial. So there is another infarct there. So quite a few things happening. As far as the pseudoaneurysm is concerned, this is the pseudoaneurysm in the mesentery. And as far as the duodenum is concerned, you've got these blushes there for which you can confirm it in the exam. Always ask for non-enhanced. And this should be, in the same breath, you should say that I will confirm it with a non-enhanced scan. Okay, thank you. So let's go to the next case. So now you have seen two cases of PAN, slightly different clinical presentation in both of them. Now let's go to next scan, which is try to again ask for mouse, can try to scroll through it, because otherwise the fun goes, isn't it? If I scroll for you.
Okay, I'm asking now for remote control.
So I have approved it. Try it. So let me give you, before you try it, let me give you the history. 76 female, uh, pain, abdomen, and loss of weight, rule out malignancy. They asked for a CT, chest, abdomen, and pelvis. The chest part was normal. So just concentrate on the abdomen. Over to you.
Okay. Now it's working, alhamdulillah. I am presenting abdomen CT with contrast. I will go through the study before comment. I can see there is pelvic fluid collection, retroperitoneal fluid collection seen around the rectum. This is associated. This is associated with. I can see here an abscess, a fluid collection, regular in shape with the air foci. I want to see if this lesion, this abscess, is it related to the pancreas, as the pancreas is the um, one of the important causes of the retroperitoneal fluid collection. The fluid collection is seen extending and not distinguished from the pancreatic tissue. It's displacing the bowel anteriorly. Displacing the bowel anteriorly. The superior mesenteric artery is seen through this fluid collection, however, and seen patent. I wanted to see if there is any other affected organs related to that soft tissue. Or if related to this abscess, I'm sorry, or if there is any bowel fistulation through this fluid collection. Actually, I can't see any. I can't see any related. One minute. I can see this fluid collection can't be differentiated from the stomach, so I can't exclude if there is a fistulation between the fluid collection and the stomach. In conclusion, there is features of pancreatitis associated with the wall of necrosis and affection of the stomach is the pylorus is could not be excluded. I want to see the gallbladder also, because the gallbladder wall is seen thickened. But I can't appreciate certain stones. This is a wall of necrosis related to pancreatitis
There
and
is no history
fistulation
of
could be used.
pancreatitis. There's absolutely
No
no
history of
history of pancreatitis.
pancreatitis. So this is maybe an abscess due to you have mentioned there is a history of neoplastic disease, right? Sorry, I
No,
was
I
busy
have not.
to check.
I have not.
Ah, um,
Give me your conclusion, then I'll go through the scan. Just give me your
uh,
conclusion.
Okay, there is an abscess seen in the retroperitoneal area with fluid collection. This abscess may be a post-operative abscess or maybe fistulation. Um, Sorry, I didn't hear exactly the history because I was busy about the control.
Okay, thank you very much. Thank you. Thank you. Now, this case, so regarding history, please remember that in the exam, the same thing will happen. History is critical for you to concentrate. Once
Mhm.
you pick up something, you have to trace it and try to see where it goes. Now, you also mentioned that this is retroperitoneum. So this is the abscess, this is the kidney, that is the retroperitoneum. This is sitting in the small bowel mesentery. This is in the peritoneal cavity. In any case,
Mhm.
let me go through it. In this case, now we have got a stomach which has got contrast. This is the pyloric canal. This is the junction, and this is the D2, and here is the D3. Now, with that, we can see that in the lesser sac, you should have used that word lesser sac. It has got this bubbly appearance of an abscess. There is some enhancement also. So, of course, you were right that it is around the pancreas. So there is an abscess in the lesser sac. Now, if you trace it as we look here, this goes, and then it communicates with this is the large bowel. So it communicates with the large bowel. And on the other hand, another ramification of it, which goes along the uh, inferiorly on the right, and this ends here in the peritoneum, sorry, in the small bowel mesentery. So it just ends here blindly. Now the question is that if you had picked it up, then I would have asked this question that we have seen that there is a small bowel, sorry, lesser sac abscess. We have also seen that this abscess is communicating or into the colon. So why is it sitting in the lesser sac? So this is a question for chat. Why is the epicenter within the lesser sac? What do you think? Anybody in chat? I cannot see the chat somehow or the other now. Okay, so somebody has said that there might be uh,
Maybe there is.
ulcer, perforation, duodenum. Good thoughts, very nice thoughts. So please remember the definitions of uh, fistula versus a sinus tract. Fistula is when two epithelially lined cavities they communicate with each other, right? Now, why is this? And this thought process was very good that somebody said that we are worried that there might be a communication with the duodenum or the stomach. And second communication is, of course, with the transverse colon. So here comes a question for chat. What can you do to highlight a communication? What can you do? What kind of a procedure can you do? Oral contrast. Excellent. So in this particular case, what we did was that we gave oral contrast and then did a non-enhanced CT once again. And this is oral gastrographin. And now what happens is that if you come here, this is the D1. So from the D1, you can see that there is leakage of contrast into this abscess, the lesser sac. And from there, you can see a ramification. Actually, you can see contrast communicating with the large bowel. And another ramification which was going here in the mesentery. So actually, there is a duodenocolic fistula. An interesting bit is that then the communication is through the lesser sac and goes right and left. So it's a complex fistula, and this case also tests your clinical acumen as well as anatomy and things like that. Okay, madam, thank you. So your last case is
Okay.
77-year-old, 77-year-old female with obstructive jaundice type of picture. They have asked for a CT scan. I want
Okay.
you to just concentrate on the biliary system. Over to you.
Okay. I'm presenting abdominal. Uh, I'm presenting abdominal CT with contrast. I want to see, to look to the biliary system, the gall bladder, and the okay. Uh, I can see there is an intrahepatic biliary radicals dilatation seen on the left side of the liver. Um, this is I want to see why also the right side. I want to see the cause of the obstruction. I can see dilatation also of the common hepatic duct with a lesion seen in the cystic duct. There is a large lesion seen inside the cystic duct and extending to the hepatic duct. The lesion is enhancing. However, routine practice, I will review also the non-contrast study. The gallbladder wall is seen normal. um, is seen normal. I want to see down the extension of the lesion. I think the lesion is extending down to the CBD as well. I want to see the pancreas. I want to see the pancreas to see where is. Sorry, I can't.
Where is the
Yes, here
CBD?
the pancreas.
Where is the CBD?
Yeah. It's this is the CBD here. Not this is the
So,
CBD. This is a lesion, a soft tissue, a malignant lesion enhancing, involving the CBD, the cystic, dilating the cystic duct, and causing intrahepatic biliary radical dilatation. Maybe cholangiocarcinoma. My routine practice, this is an urgent finding as there
show
is
me, show me the
jaundice, obstructive
CBD.
jaundice.
Trace the CBD for me.
Also, I will, this is the, sorry, okay, 1 minute. Should be the confluent, right? And then should be the common hepatic duct.
Mhm.
As here the cystic duct is cystic duct appear, so together with the hepatic duct has to get this part. This is what I think.
So trace the
This is
CBD
not.
for me. Where is the CBD now?
It's here. Should be
Just
this one.
trace it distally till the ampulla for me, till the ampulla.
Okay. Uh, it seems thin here in the ampulla.
Okay, madam. Thank you.
Okay.
So this case is a case of uh, mid extrahepatic biliary duct lesion, common hepatic duct, distal common hepatic duct, uh, and with that, which is causing intrahepatic duct dilatation. Uh, this is a cholangiocarcinoma, but the anatomy is that if you see here, we can see intrahepatic duct dilatation. This is the confluence, and now this from here to here is the still the common hepatic duct. At this point, there is enhancement here. And this enhancement is a bad sign. Actually, this is the lumen where I'm pointing out. and surrounding this means that in the common hepatic duct, distal common hepatic duct level, there is a mass at that site in keeping with a cholangiocarcinoma. Now, if we trace it distally, where I am pointing out, we are heading towards the head of the pancreas. At this site, this is the neck of the pancreas. You can see the distal CBD, which is normal, and we can trace it till the duodenum. Now, with that, we can see that there are lymph nodes. For example, lymph nodes, lymph nodes, lymph nodes. If we go into the retroperitoneum, there are lymph nodes. In this particular case, actually, if we go superiorly, there is a volvulus, a chronic volvulus of the stomach with intrathoracic stomach, and there are actually some lymph nodes sitting here also. Now, as far as the gallbladder is concerned, gallbladder is thick walled, and if you look carefully, there might be some calculi. Actually, these were large calculi, which is difficult to confirm here, but we can ask for, another what we call an MRCP or ultrasound to confirm that. Now, the key thing is that whenever, as I have told you, that when you report these scans, whatever you have made up your mind, nobody is stopping you to ask for a corona. And this is what happens in the day-to-day also. If the examiner do not want to show you, they will tell you, but you should ask. And this should be your clinical practice also. Because this part of anatomy, pancreas, biliary system, etc., you have to take the help of the coronal. Now, on coronal, this is the pancreas, and we can see that the pancreatic duct is here. We can see that this is the CBD. Now, as we trace it upwards, you can see this thick enhancing mass. And now this is the porta hepatis. So just distal, a few centimeter distal to it is a cholangiocarcinoma with all of these what we call lymph nodes. And these lymph nodes, these retroperitoneal nodes, and that node here, they will become, by definition, metastasis. Non-regional lymph nodes are taken as metastasis, and regional lymph nodes will be in the N classification of a tumor. So this is it, just to show you, which I did not want to show you, but just to show you the calculi. These are big calculi which are sitting there on this MRCP. Okay, thank you, candidate 2. Candidate 3. Now, let me make candidate 3 a co-host. So your first case is this one. If you can listen to the history. Candidate 3, you are listening to
Yes,
me?
yes, sir.
Okay, so this is a case, this patient had on ultrasound, they picked up a large mass and they asked for an MR. And they said that possible ovarian mass. Over to you.
Okay. This is axial MRI. So let me take the control.
Yeah.
Okay. This is axial MRI T2 weighted image of a patient who had a lesion detected on ultrasound in pelvic region. First, I will scroll through the whole stack of images and then I will start describing about my findings. I can see that there is a well-defined fluid signal intensity, large cystic lesion, starting from the level of pelvis and extending superiorly in abdomen with predominant bulk on right side of midline. It shows internal variable signal intensities, suggesting debrinous component in its anterior non-dependent part. In its lower part, there are some solid-looking nodular low signal intensity areas. Now I want to have a look on the ovaries to make its relationship clear about its origin. Coming to the pelvis, I cannot see the right ovary separately, and there is free fluid in pelvis as well. And I can also see there are some nodular areas of long peritoneal outline of soft tissue signal intensity. I'm concerned about patient's age as uterus is small in size if the patient is postmenopausal. Coming further down, okay. So
Actually,
it's
I
a
lost your sound. What did you say if the patient is? And then I lost
postmenopausal.
it. Yeah, the patient is postmenopausal.
Okay, so it's an old age patient with a large, complex, cystic cum solid mass lesion on right side in pelvis. I'm highly concerned about some aggressive pathology like neoplastic mass lesion. It is making close contact with adjacent bowel loops with loss of intervening planes, and there is some tethering here as well. However, there is no associated obstructive bowel dilatation. And looking at rest of abdomen, I cannot see. There are a few prominent para-aortic lymph nodes, and there is some soft tissue nodularity in the pelvic region in peritoneal outline. In my routine practice, I will also have a look on post-contrast study and on T1 weighted images.
I've given you a T1 weighted sequence.
Okay, sir. Thank you. This is axial T1 weighted image. Okay, here I can see that the anterior non-dependent altered signal intensity on T2 is bright on T1, which is suggestive of fatty component in it, and few signal void rounded areas are also visible, which are more indicative of calcific signal intensities. Okay, lower part is not included. It's only, I think, only part of abdomen is included. Yes. So I will, in my routine practice, I will review patient's previous record for any known pelvic mass lesion in past. Considering the presence of large size and fatty component, I am concerned about malignant transformation in germs in some old dermoid cyst or a primary malignant ovarian mass. So I'm also concerned about the nodularity of peritoneal outline, for which I will look on the post-contrast study to rule out any peritoneal metastatic disease. And regarding the solid areas of enhancement as well, the enhancement features of the solid areas. So in the post-contrast PET set images, I can see that there is smooth, thick enhancing wall of the cystic component. Coming down, there are irregular nodular solid looking areas in lower part of the mass. In this region, it is almost inseparable from adjacent colonic and ileal loops. And going down further in pelvis, there is slight nodularity, but no convincing solid peritoneal lesion. So it's likely a malignant germ cell tumor in right adnexa, possibly arising from ovary, and should urgently be conveyed to the relevant gynecological MDT for further management. And I couldn't see any hepatic lesion to suggest a metastatic deposit, and no definite swelling of mesentery or any acute complication related to this large pelvic mass.
So, regarding this component of the mass where I am pointing out,
Yes.
what is this made up of, this component?
Sir, in my opinion, it appears to be a non-dependent fatty component and a dependent fluid signal intensity component with few internal signal voids, which are more likely to be calcifications, which appear to be floating in the fat. and
Just 1 second. I showed you a T1 weighted sequence, which I'll show you again. Here you are.
yes, sir.
So what do you think is happening?
There is a fluid level in the lesion.
Mhm.
So it can be variable stages of hemorrhage or coexisting fat with it.
Coexisting fat with it.
But I'm more convinced for the non-dependent fatty part because it was showing suppression on fat set images.
Why isn't it causing suppression here? Which kind of a sequence is this?
So it's T1 out of phase.
Mhm. So this portion here, it has showed what is the behavior of this versus this.
Sir, I can't see your cursor.
Okay. So my point is, let me, this is a T1 weighted sequence without
Yes.
fat saturation. Okay.
Okay.
Now just look at the signal intensities of this mass, and then we have got uh, out of phase, a post phase T1 weighted sequence. So what has
Okay.
happened here?
Um, so it was completely low on non-fat set T1, and now it is showing few internal bright signals.
Here you are. It was not low. It
Okay,
had
okay. So it is showing loss of signal. Yes.
mm,
Maybe there's some microscopic fatty component in it.
okay. And in the anterior part, what kind of a
So
component is this?
it appears to be fatty.
So is it intracellular or extracellular?
This is extracellular.
Okay. Now review the liver again on this sequence.
Okay. So coming back to the area of liver. Okay. Here I can see that there is a completely lost signal in a rounded lesion in segment 7 of subdiaphragmatic part of liver, which in my routine practice I will correlate with in-phase imaging on T1. If it shows loss of signal following in-phase and out-phase imaging, then it will be a fat-containing lesion, which can be a metastatic deposit from a germ cell tumor.
Okay, thank you. Now, uh, this case is immature teratoma. The most interesting part of this is that this patient is 78 years old. So I did not, because 78 is very, very unusual presentation. So I did not want to go into that. That's why I did not give you the age initially. I did not want to misguide you. Having said that, the candidate did well. We are picked up multiple features and some other features. Let me take through that. So, the terminology wise, these days it is known as immature teratoma. Mature teratoma, the word dermoid is now technically, instead of using the word dermoid, you should use the word mature teratoma. And this is an immature teratoma. In this age group, it is very rare, but this is what happened. Now, if you see here, this is a T2 weighted sequence. On this T2 weighted sequence, we can see this high signal. We can see fluid level, high signal here. Of course, on this T2, we are not sure whether this is fat or this is just fluid. Uh, and then we have got this component here. This component is ugly looking. It has got solid as well as cystic. And this is the component which you will see when post contrast there's a bit of necrosis also, so it enhances. This is that malignant type of picture, and then it is sort of adherent with the uterus, and this so that was the finding. Now if you go superiorly and see the maximum included on this scan is uh, till here where the liver is not included. So I showed you an opposed phase T1 weighted sequence. The key point is that please remember that in an opposed phase, the opposed phase T1 weighted sequence, there will be signal dropout in intracytoplasmic or intracellular fat, but the extracellular fat will not show signal dropout. And the main evidence is that you can see this fat, subcutaneous fat, it does not show any dropout. Another thing is that the candidate did very well, where picked up the sequence herself, and you have to do it because the main thing is to there is a what we call an India ink artifact or etching artifact along the viscera, along the kidneys, along the liver, this dark line, and from there you should know that this is an opposed phase T1 weighted sequence. Now, right now you are handicapped because you have not seen a T1 with non-fat saturated, and you should ask for a T1 non-fat saturated. When I showed you, you could see that there is a bit of fat here. And this was also fat, but this fat is extra cellular, extra cytoplasmic, and this one is intracytoplasmic, intracellular, and that is why it shows signal dropout. On this sequence, as we go to liver, we can see that there is signal dropout. Actually, there is more than that because you can see tiny, these are metastases, immature teratoma with metastasis. So then we go to this is sorry, this one I had shown you already. So this is a T1 weighted non-fat saturated, and you can see that these components which are bright became low signal, and this one did not become low signal. Now on post-contrast sequence, whenever you see a post-contrast sequence, of course, you should ask for a pre-contrast fat saturated. This is what it was just before contrast was given. Everything becomes dark, so the extracellular fat has also become dark. And on the post-contrast sequence, we can see, that this ugly area, it shows some necrosis, some enhancement, and this is the fatty part. So this is an immature teratoma with metastasis. So what happens is that I will show you a CT scan because you can get this thing on a CT scan also just to in immature teratomas, what happens is that usually there is rupture and this goes into the peritoneum. So always look for that. In this particular case, there is something here, some calcification here, but this was not fatty inside it, but might be a slightly chronic type of a deposit sitting there. If we go towards the liver, we can see uh, some calcification sitting on the serosal surface, maybe part of the same thing. And here, this is that metastasis which we had looked on the opposed phase T1 weighted sequence. As far as the main lesion is concerned, this is all fatty. As we go there, this is that ugly looking, enhancing nodular malignant type of mass. So overall, this case was a immature teratoma with hepatic metastasis and possible peritoneal. The peritoneum part, of course, was not visible on MR. Okay, well done. You did very well. Now, let's go to next case. So this case is interesting history. 68-year-old 3 months ago, the patient fell down, had a hematoma in the frontal region. That hematoma is not going down. They thought that it will resolve itself. Then the patient has developed some pain and headache also. Over to you.
This is axial MRI brain flare image of a patient who is 68-year-old and has history of fall, followed by intracranial hematoma, which is not
It was,
going
excuse me, it was not intracranial, it was scalp hematoma in the.
scalp hematoma. Okay, which is not going despite of conservative management. So I will scroll till the last cut. I can see that in the intracranial structures, there is no hydrocephalus, no midline shift or mass effect. I can also see that there is a midline uh, flare hyperintense signal intensity, well defined lesion in scalp, anterior to frontal bone in midline with overlying bulge. The underlying frontal bone is showing hyperintense edema signals, and the left frontal sinus is also fluid opacified. I cannot see any definite bone defect in this image. In my routine practice, I will also review patients' any CT brain available or bone window to look for the changes in underlying bone or any defects. This is axial
When you,
T2,
yeah,
in which I can see that the lesion still shows hyperintense signals and shows underlying calvarial edema signals, which are hyperintense mainly. And the frontal sinus shows intact walls. I cannot see any cortical disruption in these images. If, coming to the intracranial structures in this area, there is no intracranial collection or abnormality. So, in a 68-year-old patient, to conclude my findings, I will also like to have a look on diffusion-weighted and post-contrast images. Other than that, I can also see there is fluid opacification of mastoid air cells and some cyanomucosal disease as well in rest of paranasal sinuses that need to be further evaluated. If the patient has pain in this swelling and history of fever or any sinus disease which was pre-existing before trauma.
diffusion. Scroll through
So
it,
on,
you will come to the diffusion. This is the T2 component of the diffusion.
yes, sir. So on high B value diffusion weighted images, I can see that the lesion shows central high DWI signal, which I will correlate with ADC for presence of true diffusion restriction. Similar high signal is there in underlying frontal sinus. So having a look on this, if it is showing true diffusion restriction on ADC, my first differential will be an infective process, which can be sinusitis with osteomyelitis and pot puffy tumor appearance. And I will also correlate it with post-contrast imaging if available.
Let me,
So
just 1 second. I think I've got a fat saturated. Over to you.
okay, this is T1 fat sat post contrast, in which the lesion shows central necrosis and peripheral thick rim of enhancement, and the necrotic fluid component was showing diffusion restriction. So, likely infective process, osteomyelitis of frontal bone with overlying abscess formation in subperiosteal location. I will refer the patient to ENT and a neurosurgery MDT for further management, which can be antibiotics and pus aspiration and analysis can be done for accurate management.
Anything happening intracranially?
Coming to intracranial structures, there is uh, underlying brain parenchyma does not show any abnormal enhancement. However, there is smooth dural enhancement in adjacent part of brain, which suggests some meningeal spread of infection.
Okay, thank you.
And
Thank you. That's fine. So this is basically an interesting case, and this is hot off the press. I reported it 3 days ago, actually. Now, so the patient actually uh, had banged the forehead, and there was a hematoma, and then presented back with this 68-year-old. Now, the candidate did well, except for 2 points, which I will point out as we go through it. This is a flare sequence, and I think when you were describing it, you did mention in your description that on this flare, it would have been better to say that in the beginning, that this is a flare sequence on which we can see. Now, if you see here, the key point is that look at the bone marrow. Flare is a useless sequence to look at the bone marrow, but even here, you can see that something is abnormal. So this is the inner table, this is the outer table, and then this focus is fluid signal. Rest, there is something abnormal happening, and of course, there is a soft tissue component. Now, I showed you a T2 weighted sequence. And the key thing is that for marrow, because we are worried about osteomyelitis of the skull, and you must and should have asked for a T1 weighted sequence. That is something which you missed. Now, here we can see that there is some fluid intensity focus similar to this one, and then there is some abnormality. Now, T1 weighted sequence, look at this. This is a T1 weighted sequence. And T1 weighted sequence is the best sequence for bone marrow in the skull also. Develop your eyes regarding this is a osteomyelitis, but then metastasis, etc. Look at this, that we have got an outer table, we have got an inner table, and we have got an diploic space. Because this patient is 68, the diploic space has got a lot of fatty marrow. In every young patient, you might see less fatty. Now, if you go here, you can see abnormal signal. So please remember the definition that in marrow, low signal on T1 and high on STIR or any T2 weighted sequence, that is abnormal. With that, if you see here, this is the frontal sinus. Within the left frontal sinus, there is a localized collection, and then there is soft tissue. So the candidate did well did not ask for T1, which should have been asked, and then asked for diffusion, which was fine. On this diffusion, we can see that there is a bit of restriction here, and there is, that frontal lobe collection localized, and this is the soft tissue. And on post contrast, we can see that everything is enhancing, and then this thing also show enhancement. And here, the key point is that keep looking for intra. They will always show you uh, in head and neck territory, favorite exam cases are infections with intracranial manifestations. So that should have been, even if there was none, should have been pointed out. But in this particular case, there is leptomeningeal dural enhancement bilaterally. So that has to be pointed out. So, and another thing is that this is by definition subperiosteal abscess. Pot puffy tumor is a description which we call it, but call it a subperiosteal abscess. Otherwise, well done. Your last case, let me make it slightly bigger. Now, this patient is 74-year-old male. Patient presented with jaundice, and the gastroenterologist have did an OJD and have done a procedure. After the procedure, some symptoms have occurred, pain, etc. So they've asked for this CT scan. Over to you.
This is axial post-contrast venous phase CT abdomen of a 74-year-old patient who had history of jaundice, and some intervention has been done. I'm scrolling through the images and I will go till the last cut. Okay. So coming back to the main, it's a male patient. Coming back to liver area and along CBD, I can see that there are air density foci within CBD and intrahepatic biliary channels suggestive of pneumobilia, likely due to recent procedure, and it also suggests a patency of the biliary channels. Going down, I can see that there is diffuse circumferential wall thickening of common bile duct, which is more evident in suprapancreatic part. However, I cannot see any definite discontinuity in the wall of CBD. To make it confirm, I will further, in my routine practice, I will review it in other planes, other formats as well. In peripancreatic region, I can see that there is fat stranding, fluid, thickening and ill-defined outline of duodenal wall, and few air density foci are located outside the bowel lumen and outside the biliary channels, close to porta hepatis and peripancreatic region. Going down further, these are located close to this area of ill-defined duodenal wall thickening. As patient had some procedure done for obstructive jaundice, my first possibility thought process is that it can be ERCP done for this patient. So if patient is post ERCP and this type of finding is there, and gastroenterologist concerned about patient symptoms, then this can be due to duodenal
Stop here.
injury during.
Can you stop here? What do you think is this? And this is the procedure which was done. Over to you.
So here in this region,
Yeah.
okay, and the stomach is partially fluid filled, and the gastric pylorus has been there's some stent placed through the pylorus, and there is circumferential edematous wall thickening of pylorus and first and second parts of duodenum. So possibly there was some stricture or narrowing for which they have bypassed by placing a stent.
So this
Or
stent is between.
it's between stomach and first part of duodenum, duodenal cap and
Where
pyloric
is the
canal.
first part of duodenum?
This is
Where is the gallbladder?
okay. Okay, so this thing has communication with gallbladder wall. Yes, because within this area, I can see that the duodenum is going down, and this structure, this metallic device, is extending into gallbladder.
Mm-hmm.
So maybe due to they have, if this procedure was done, possibly they tried to drain the gallbladder, and
Why will they try
that
to
might
do
be.
gallbladder like this?
Yes, sir.
Why will they drain the gallbladder like this?
Otherwise, this metallic density is not typical for being a biliary stent. Its shape is not ideal for that.
Mhm.
Gallbladder uh, communication could be made in case of obstructive jaundice if it was markedly distended. One possibility is that we do open cholecystic cystostomy, or there might be some internal drainage procedure done, or there was some pre-existing fistula there.
Okay, look at the duodenum.
Okay, so coming to duodenum, due to its ill-defined outline and periduodenal air density foci, I'm concerned about some perforation in this area, post endoscopic perforation. And coming down further, I cannot see any large fluid collection or mass lesion in this region.
Okay, give me your conclusion and also tell me what has been attempted and why has it been attempted, and what are the complications of whatever has been attempted, which you can see on this scan.
Okay. One possibility is that they might have tried to drain the biliary system, but in some cases, when there is some, I'm just making an assumption that there was some obstruction between gallbladder and CBD, like in Mersey syndrome or anything obstructing CBD from outside, and they can't approach this area. In that case, they might have tried to drain gallbladder by internal drainage procedure. And other possibility is that
Okay,
considering the age of the, yes.
that's fine. In the chat, anybody knows what has been done? What kind of stent is this? I cannot see the chat. Stent migration. Cholecystodudinal stent. What kind of a stent is this? Yeah, some of you know it. Excellent. I have to name you Ming. Excellent. Well done. This, in FRCR exam, it happens whenever some new device come and things like that. By the way, it has been happening since 20 years. They will show you what is this, that kind of a thing. So this is a very, very good case to learn something new. This device, if you Google it, Axios, Boston Scientific. So this is self-expanding stent, very interesting shape. So basically what they do is they have to drain the biliary system. They can drain it into the duodenum, they can drain it into the pyloric canal. In this particular case, so it is self-expanding, it expands like this and expands like this. And so this case is a story case. And these kinds of cases are very important for the exam. It tells you a story. And the story is that a gastroenterologist has passed this Axios stent from the pyloric canal to the gallbladder. So biliary gastric, drainage or fistula. And with that, you can see that there is pneumobilia, etc. I'll come back to that aspect. Now, why have they done it? They have done it. If you see the duodenum, let me take you uh, to distal. This is D3, D2 junction. I am tracing it upwards. I am coming superiorly. I am coming towards the ampulla. And you can see that the lumen is completely infiltrated, gone. There is a mass there. This mass actually is causing obstruction of the CBD. So the CBD is obstructed because of the duodenal. So this was a duodenal carcinoma. So what they have done is they have done the procedure for temporary. I think these things can go on for about 2, 3 months, the life, I mean to say. So they have caused a bit of complication, not great, but a bit of complication. What is the complication? The complication is that there is a bit of fat stranding. Some air bubbles have gone around in this region. So they must have caused minor perforation, which is not, this will resolve with conservative management. And then you did point out that the patient look at the wall of this CBD. It is diffusely enhancing. So diffusely enhancing wall means that there is cholangitis type of picture, which is secondary to the effects of that. As I've told you, nobody is stopping you to ask for a coronal. In this region, coronal is critical. Think how you report them, describe everything, even say that in my usual practice, I'll see it on coronal also. But coronal, just for teaching, if you see the coronal, First of all, uh, look at the connection. Look here. This is the pyloric canal, and the stent has gone there. Axios, Axios, axios. And with that, you can see this enhancement, and you can see everything is enhancing. This is what we call cholangitis type of picture. Now, look at the duodenum. So you see, this is the outer wall, this is the inner wall. It's completely obliterated. So there was a carcinoma actually sitting there. This is a duodenal carcinoma. So I will show you the pre-procedure just to, because that per se can also be an exam case, but this is how the patient presented initially. The patient presented initially with, this CBD is dilated, CBD is dilated, and this CBD goes till the ampulla. Interestingly, uh, pancreatic duct is not dilated, so double duct sign is negative. Usually we see it in malignancy. But now look at the lumen. I am at D2, D3 junction. I will trace it, upwards, and complete obliteration here, complete obliteration. And then you can see the lumen. Want to confirm it? You can confirm it on here you are. So this is the pancreatic duct, this is the CBD, and this is the lumen, which is completely obliterated. Okay, candidate 3. So I wanted to show you this stent. Okay, thank you. Candidate 4, let me make candidate 4 a co-host. So your first case is just 1 second, please. A&E case, acute abdomen. So this patient is a 84-year-old, came to A&E, classical acute abdomen, very tender, things like that. And over to you.
Okay, I am presented with the CT abdomen, photovenous phase. This is a patient which came through A&E with acute abdomen. First, I will scroll through the whole stack of images. Then I will start commenting on my findings. So, in the region of interest, I can see there is a bilateral pleural effusion more on the right side with passive basal lung atelectasis. There is an evidence of hiatal hernia and a mild dilatation of intrahepatic biliary channels is seen. The CBD is also dilated till its end. Pancreatic duct is slightly prominent. However, pancreas is atrophic markedly, maybe due to old age of the patient. Now there is a perinephric thickening with thickening of anterior and posterior renal fascias. Also, lateral lateroconal fascia is also thickened, and there is an collection seen in the Morrison's pouch with multiple foci of air. This collection is also extending into the right paracolic gutter and down till the pelvis. There is a thickening of the adjacent bowel loops is also seen, likely the ascending colon, and there is congestion of the mesentery and omentum. Okay. So I would also like to see the coronal images.
Just 1 second, please. Here you are.
Yes. Okay. There is a multiple incidental finding of multiple diverticulosis, which is involving the transverse colon, and few diverticula is also seen in the ascending colon, and there is marked thickening of the ascending colon and the cecum with enhancing walls. Terminal ileum is also slightly swollen and thickened. There is associated significant fat stranding is also appreciated. There is some structural nerving is seen at the level of the hepatic flexure. However, the transverse colon is normal and the rest of the large bowel is also appears collapsed, but few diverticulae also appreciated along the descending colon and the transverse colon. So, in conclusion, I am concerned about the infective disease process, which is involving whole of the ascending colon with structural nerving at the hepatic flexure and possibility it's some perforation occur at this site maybe due to the complicated diverticulosis, and there is an abscess formation in the abdomen. And
So the location of the perforation is where?
sir, it's at the level of the hepatic flexure. It's structural nerving is present beyond which is normal in caliber, whole of the colon.
Okay, thank you. So this is a fine touch case. Now, first of all, candidate 4, you should have asked for, uh, lung window for the air, isn't it? In any case,
Yes, sir.
I think you just saw it and you did not ask for it. Oh, in any case, now the interesting bit is that if you see here that first of all, there is extraluminal air. Now, extraluminal air means your area of interest is around the cecum and the ascending colon. Ascending colon. There are air bubbles. Of course, you can ask for a lung window or a bone window, whatever you want see to see extraluminal. In this case, you don't have to because there is fluid and you are very confident that you are sitting outside. Now, a bit of fine touch. In this area, this is the cecum. So the question is, what has perforated? Now, actually, you can see a defect here. There is a defect here. And this is ascending colon. There is a defect here. You can see it. You can see this deficient wall here. Now,
Yes.
what has happened? Now, as we go superiorly, sorry, I've gone inferiorly, so I will go superiorly. As I go superiorly, we are coming to the hepatic flexure. At this point, what is happening? You can see this enhancement. So I come into the lumen here, this thing here, and then it goes, and then what is it continuous with? So if you see here, there is Mr. Gallbladder sitting here. And the gallbladder is totally contracted. Enhancing wall contracted. There is a stone there, and there is enhancement, and this enhancement is tethered with the large bowel, and actually it is fistulating inside it. So there is a biliary colic fistula. This fistula is causing that stricture which was better visualized. You can see it on axial also, but because of that fistula, there is a stricture, and this is that stricture. So let's see it again. So we are into this. This is the gallbladder and contracted gallbladder, and here you are. Please remember that whenever there is fistula, the walls will enhance. So here it is communicating with the hepatic flexure or the junction with the ascending colon, and there is a stricture. This stricture is, of course, inflammatory stricture. Because of that, there is proximal dilatation. So this is the point of transition. And if you measure it, this is about close to 5.8 to 6 centimeter. You know, of course, cecum up to 9 centimeter is taken as impending signs of perforation. This was less than that, but actually this perforated. So the etiology is interesting, and that is what this case is about. You see this and this, how it fistulates and how this makes this. Of course, there is biliary dilatation and all those things, but I was not interested. I was mainly interested here. Okay. So next, second last case, easy case. Over to you. This case is an 18-year-old A&E, disoriented fever. Patient came disoriented and fever.
Okay, I am presented with the CT brain non-contrast images of 18 years old patient which present with history of fever presented through emergency. I can appreciate well-defined intraaxial cystic lesion with some debrinous type of contents within the left frontal lobe. It is causing subfalcine herniation and there is associated edema is also seen. It is causing significant mass effect over the uh, frontal horn of the left ventricle. I am looking at the rest of the brain parenchyma. No other similar lesion is appreciated in this area. So, as the patient has history of fever, I would like to see the post-contrast images to see any peripheral post-contrast enhancement in this area. Okay, and the post-contrast images, it shows peripheral post-contrast enhancement. Images are not scrolling. I ask the control again. So it shows peripheral post-contrast enhancement. No, I am concerning about the abscess in this case. Or other so I am looking at the cause. There is an evidence of soft tissue attenuation material opacifying the left frontal sinus, which is suggest a sinusitis, and I assume that that is the area due to which frontal lobe shows hypoattenuating area and there is a development of abscess formation in the left frontal lobe. In my routine practice, I would like to check on the bone window to see any bony defect is present or not. So on the bone window, there is a defect is appreciated along the posterior wall of the left frontal sinus. So in conclusion, it's a complicated left frontal sinusitis with intra-axial abscess formation in the left frontal lobe. I would urgently refer this patient to the neurosurgery team for the evacuation of this abscess.
Okay, so it was an easy case, and the point is that key thing was to ask for a bone window, which we did, you did. But did you describe the findings related to the abscess, what it is doing to the brain? You
Sir,
did
I
not.
said it is. Sir, I said it is causing subfalcine herniation, causing compression
Herniation.
and the yes,
Okay,
sir,
okay. So,
and effacement of the ventricles. Yes, mass effect.
right. So, if you see here, this is a brain abscess. It has
Yes.
caused smooth walls. Now it is causing subfalcine herniation. When there is subfalcine herniation, always comment on the contralateral temporal horns. In this case, this is the contralateral temporal horn, which is prominent as compared to the ipsilateral. And what happens is that there is compression at the level of foramen of Monro. So this will cause dilatation of the contralateral ventricle. You can, if you strictly, what is the reason? This is unilateral hydrocephalus because foramen of Monro is compressed. So it will be a good idea in your description to tell the examiner, don't waste time, but instead of using subfalcine herniation, say, why is it subfalcine herniation? You can see midline shift, you can see compression of the ipsilateral frontal horn, you can see dilatation of the contralateral temporal horn, overall in keeping with subfalcine herniation. Now, if you go to fine touch, usually I don't do it, but in this case, if an examiner asks you, you should know, to the, now we are going into, the midline shift, how much is it? So, uh, anything, 2 centimeter is taken as extremely, alarming. And why I am showing you, usually you don't have to, but in another context, this can be asked. Uh, Less than 1 centimeter is fine. Between 1 and 2 is considered significant. More than 2 is considered very bad prognostic sign in the context of, let's say, a subdural, extradural, etc. So this concept should be there because this question has been asked in the exam, more than 2 centimeter. Now, with that comes transtentorial herniation. So you have to develop your concepts and describe the finding and then infer that there is transtentorial herniation or bilateral transtentorial herniation or whatever. So what happens is that if you see the midbrain in this case, if you stretch your imagination because it is such a tight brain, definitely the uncus is sitting here. If you see the midbrain, it is compressed. All the cisterns are effaced. And if you see the suprasellar cistern, it is completely effaced. Suprasellar cistern is a effacement is taken as a sign of transtentorial herniation. So one can argue that this might be bilateral transtentorial herniation, more marked on the left side. But idea in the exam is that impress the examiner with your description because the concept that why is it transtentorial herniation. So for the subfalcine herniation, that there is an ipsilateral mass, midline shift to the contralateral side, ipsilateral lateral ventricle is compressed, contralateral lateral ventricle, particularly the temporal horn, is dilated. With that, the midbrain is distorted. The cisterns around the midbrain are all effaced, and suprasellar cistern is completely effaced, and this is in keeping with transtentorial herniation. So use all of this to get a bit of more brownie points. Now, as far as bone window is concerned, so there is a dehiscence here, posterior wall, and there is something in the anterior wall. Okay, last case of the day is coming up. So this is a 74-year-old male. Patient came to A&E, and the surgeons have said that the pattern of pain abdomen is that we want to rule out, please rule out mesenteric ischemia. So an angio has been done. Over to you.
Okay, I'm presented with the CT mesenteric angiogram, and there is a suspicion of the mesenteric ischemia. So I am looking at the vessels, the celiac trunk normally opacified with the contrast, including splenic and the hepatic branches. The superior mesenteric artery shows normal enhancement till down its course. And now I am looking at the inferior mesenteric artery. But I couldn't appreciate any definite thrombosis in these three vessels. Renal arteries are also normally originating and opacified with the contrast. Some atherosclerotic changes seen in the aorta, however, no evidence of aortic dissection or abdominal aortic aneurysm. Down to the level of the iliac vessels. Okay, there is no active contrast extravasation seen. I couldn't appreciate any indirect signs of mesenteric ischemia, like I couldn't appreciate any bowel wall thickening or edema or free fluid in the abdomen. No, I am looking as systematically the liver is normal, and rest of the structures like spleen, adrenals are okay. Simple cysts seen in both kidneys. In the region of the pancreas, there is enhancing structure seen in the region of the pancreatic head, likely in the uncinate process.
Can you point it out to me?
Yes, it is.
Is this the uncinate process? Your finding is correct, but is it the uncinate process?
Sir, uncinate process is usually slightly medially, but this is a region area of enhancement is seen in the ampullary periampullary area close to the head of the pancreas.
What do you mean close to the head of the pancreas?
मतलब abutting
What
the head of the pancreas.
is the relationship with the duodenum?
It is inseparable from the duodenum, from the second part of the duodenum. And it is shows enhancement in the arterial phrase.
Okay.
So keeping it with the enhancing tumor, I am concerned about the neuroendocrine tumor in this region.
Which one?
It's a specific triangle in this area, which
So what else you should rule out then?
I would rule out the other,
On the
any
scan.
other. Yes, sir.
Any other lesion? Okay. What else?
Any other lesions, and to rule out any enhancing lesions in the liver, which I couldn't appreciate.
And what else?
And any tumor in the mesentery, to see other associated neuroendocrine
Okay.
tumors.
Final conclusion. Final conclusion.
So it's a neuroendocrine tumor close to the
Thank you.
duodenum. Yes. Okay, sir. Thank you.
Thank you. Yeah, I was very, very happy with the way you tackled this case. The only thing is that once you reach it, then there was a few hiccups, which I'll tell you. Otherwise, I was very, very happy because of the, and this is what happened in real life also. I have seen five, six, neuroendocrine tumors in my life, which the classical, from A&E, mesenteric ischemia, and you pick up these things. And why do you pick up? I'll tell you. Now, in this particular case, you went through your angiography protocol, which was good. You ruled out everything happening in the gut, and then you picked up this thing. Now, here comes a bit of fine touch. Now, this is, if you see anatomy, now I've shown you quite a few cases of the duodenum, the pancreatoduodenal junction and things like that today. So my idea was to pick up cases in that region just so that your anatomy, your protocols, your eyes are developed in this region particularly. Now, this is the neck of the pancreas. This is the head of the pancreas. This is the uncinate process. This is the uncinate process. Uncinate process is posterior to the superior mesenteric vein. In this case, the vein, of course, is empty of contrast for the simple reason that this is arterial phase. So uncinate process, that was a bad one. This is far away, miles away from uncinate process. Now, this is uncinate process. This is the head. Now, look at the duodenum. Now, if you see here, this is the D1, this is a D2. D2 is sitting, now this is the CBD where I am pointing out. The pancreatic duct comes here. So still we are at D2, and you can see this is the pancreatic duct. It joins the CBD. So this is the ampulla, still the duodenum, and this mass is sitting here. And just concentrate on the duodenum. Now, the duodenum goes and gets connected with the D3. So it is sitting outside the loop of the duodenum. It is sitting outside. But this area is classical gastrinoma triangle. And I've shown you this picture quite a few times from radiographics. You can Google it, radiographics, and good picture which tells you that all of this area, including the area where our tumor is known as gastrinoma triangle. So this word was not coming to your mind. Now, as soon as you have picked up a gastrinoma, you should, three things. First, multiple lesions, you did very well, where you said that I will look for multiple lesions. Second, metastasis, you did very well. But the third thing is look at the stomach. What do you think is happening to the stomach? You see, these are what we call rugal folds. You have to develop your eyes to differentiate it with wall thickening, but these rugi are thickened. Particularly when you pick up that thing, you can then confidently say that even you say that this is suggestive of rugal thickening. So with rugal thickening, it becomes Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. So these were the few points in the feedback. Okay, otherwise you did very well. Well
Thank
done.
you, sir.
Now that is it. So next week, again, I will take the session. Is there any question? Anything? Right. You are most welcome. And next few sessions, I will continue with the Australia. What was that? I heard the name of Australia. Wow. Oh, I'm impressed. So happy to hear from you. Thank you from Australia, 6:50 a.m. Absolutely brilliant. So happy for you to be logged in from Australia. Thank you. So next week, similar session. I try to give you a mix and match type of a session, and usually my emphasis is on acute presentations. So I will, I think, continue with similar type of a, mix of cases next time. Okay then. Thank you very much. So when somebody is asking about vasculitis in bilateral hematoma. So polyarteritis nodosa, by definition, is a vasculitis. And but because of the pattern, because of the medium side arteries, because of the which arteries are involved, that should be up there in your differential diagnosis. By definition, polyarteritis nodosa is a vasculitis. There will be, the pathology is that there is necrosis of the wall, and that is why there is aneurysm, what we call aneurysm. I think I forgot to share the feedback, so I will now share it. Okay then. Thank you very much. Thank you.